All right, everyone, it's 5 past the hour, so I think we'll go ahead and get started. First of all, thank you to everyone so much for hopping on this webinar today. Good afternoon or good evening, depending on which part of the globe you're in. Today, we're super excited to have with us Dr. Maria Ngala, who is a doctorally prepared and board certified nurse practitioner specializing in family psychiatric mental health. Dr. Ngala has experience in working with children and adults diagnosed with trauma, depression, bipolar disorder, anxiety, schizophrenia, psychosis, ADHD, and autism spectrum disorder. Dr. Ngala has also worked and trained extensively in perinatal and mental health, receiving certification from Postpartum Support International and Peripartum Mental Health Professional. Dr. Ngala is a nursing professor at Arizona State University in the United States, where she teaches mental health and pharmacology courses. She precepts psychiatric nurse practitioner students for various schools across the country. She previously served as a psychiatric consultant across the country for pediatricians, primary care doctors, and OBGYNs to assist in managing the mental health of complex patients. Today, Dr. Ngala is going to be giving us a crash course in managing mental health and primary care, and I'm going to pass over the microphone to her.
Hi, everyone. And you guys can all hear me okay? Nods, yes? Okay.
All good.
Perfect. So today we're going to go over a little bit about how to manage mental health in primary care. I tried to keep this as almost surface level as possible so we could cover a lot of information versus going in depth on one or two major things. So as far as today, we're going to look a little bit in developing comfort in the evaluation and treatment of depression, postpartum and perinatal mood disorders, which include postpartum depression and postpartum psychosis, and bipolar disorder. Anxiety and trauma are kind of integrated in these different topics too, so we'll kind of overview those as well. We're going to learn to assess for suicide and homicide, along with understanding level of risk for the types of answers these assessments come up with. And then we're going to learn to recognize the signs and symptoms of psychological trauma. And then we're going to go over a couple of examples at the end. So the information that we're going to cover, I have a few different vignettes that we can talk through and start kind of kickstarting the question and answer phase at the end. So that way we can have some participation and you guys can start applying the knowledge that we are covering today. So before we have any psychiatric evaluation or treatment, the first thing is we need to make sure that our patient is medically evaluated, worked up, and that there are no medical causes that could be driving psychiatric symptoms. So some examples of this: if you have a vitamin B12 deficiency, so people who don't have a lot of animal products in their diet may not have proper B12. If you don't have proper B12 in your body for long enough periods of time, you will start to have psychosis. So you will start to have visual hallucinations and auditory hallucinations. That can be in conjunction with different kinds of nervous system problems as well, which could look like a tremor. It could look like fatigue, just different sorts of dysfunctions along the nervous system. You guys are going to know more than me in the primary care. But low vitamin D could cause depression. HIV can cause psychosis. Thyroid issues can cause depression, they can cause mania, they can cause all sorts of different problems along that line, strong anxiety. Seizures and head trauma have different sorts of psychiatric symptoms that can come along with those. And then anything else like fluctuating blood sugars, sleep disorders can affect your patient and also cause psychiatric symptoms. So what we're gonna have to remember here is if we do the medical workup, comes out clear, then we know that we're going to be treating the correct thing. If you have a patient experiencing anxiety from thyroid or from some sort of an infection, the treatment's going to be significantly different than it would be if this is an organic psychiatric disorder. So we're looking today at organic psychiatric disorders. We're going to start talking about depression. So what is depression? I feel like sometimes depression has a stigma with it that maybe people think that it could be that you're stressed or your brain might be overwhelmed or that you're weak, that you just can't handle the things going on. What we have to remember about depression is it is a chemical imbalance and it is genetic oftentimes. So if somebody in the family has it and has that gene for it, that could get turned on in the next person and the next person and the next generation down. It can be triggered by life stressors, but at the end of the day, this is a chemical imbalance and we have to treat it as such. We have to treat it the same way we would treat diabetes and not having insulin in the body. Depression means that we don't have enough chemical neurotransmitter in our brain to help us function. So how do we know if it's depression versus something else? Depression requires 2 or more weeks. So consistent weeks with your daily mood being low. So feeling not necessarily like you're sad and crying, but just feeling like, I don't feel that good. I don't feel the same. I'm not feeling joy the same way. I'm not feeling motivated. I don't really feel hungry. I don't feel like I can sleep. Sometimes there could be suicidal thoughts that might happen with this. So I wish I were dead, or I want to kill myself. There could be movement changes, which means that you're feeling very slow, like you feel like you're moving in slow motion, or you feel like you're moving very rapidly. You're very anxious and you can't sit still. Fatigue, so feeling like, the idea of getting out of bed today is so exhausting, I'm just going to lay down. There could be sleep changes, meaning that you're in bed for 20 hours a day and you just can't get up. Or there could be poor focus. So depression could be a combination of these different symptoms, but we always want to remember the key symptoms here are low mood and feeling like you don't have much joy. The clinical word for that is anhedonia. When we are asking ourselves, is this depression, or is there something going on like a divorce, a loss maybe in the family, a loss of housing, just some sort of a traumatic event that's happened, we want to look at how much is this affecting function and how long has this been going on for. So if we've been having 2 weeks of these symptoms every single day, and it's starting to affect our function, we can't care for our family, we can't care for ourselves, we're not getting ready in the morning, we're not able to shower or do our daily cooking, anything that we would normally be doing on a daily basis, that's when we should be looking at the possibility that this could be depression. So we want to always ask ourselves, how is this affecting this person's ability to function? Can they do their daily tasks? Depression is a major cause of disability in the world, meaning that like right under some medical problems, depression is huge. People just can't function with it when they have this and it's not treated. So we have to look at other situations too. So see what's going on in the patient's life. Did they lose somebody? Grief is different. We can grieve and that can be okay to be sad, but it's going to be fluctuating. If somebody wants to die to be with their lost person, whether that's a partner or a child, that can be a normal part of grief. But once we start hitting that, like, I don't care, I just want to die all the time, it doesn't have anything to do with anything else. This is spontaneous. This is independent of other things going on in my life. Even if things changed, I wouldn't feel better. That's when we know this is depression. Some people also don't experience things where they understand to say like, I'm feeling sad. They might experience headaches or stomach aches instead and say, my stomach just hurts. I don't know what's wrong, but I'm feeling stomach pain all the time and I'm having headaches all the time, but there's no medical background to that. That could also be a sign of depression. Somebody just doesn't know how to verbalize their mood as well. And then we have to remember that people with depression may be able to put a face on and they may still be able to laugh and do things. It's kind of hit or miss, but people can cover it up and continue to live. It doesn't mean it's not there just because they've had a couple of good days. How do we evaluate this? There are tools that we can utilize. I'm not going to go over this in depth, but the PHQ-9 is a reliable, valid tool that's been used globally. It's available in different languages, but basically this is just going through a series of 9 questions, which are the criteria I talked about. And they're looking at, does this not happen at all? Does this happen sometimes for you? Does this happen most of the time or all the time? And then depending on what they have here, say they scored all 3s all the way down, they'd be looking at a severe depression. And it's going to give you a proposed treatment plan for that. So are we looking at medication? Are we looking at just monitoring them and having them come back in a couple months and seeing how they're doing? So this would be a really good tool to use for just some guidance to say, is this depression? Is this not depression? I can't really tell. But remember to always ask yourself, is this affecting the patient's ability to function? How do we manage this? So lots of different things. We're going to go over just some mental health tips at the end too, just generic for everything to help promote mental health and mental wellness for some people, but encouragement to try to have the patient set small goals for themselves. What I mean is, if you set a big goal, like I'm going to go to work the entire week and I'm going to have a great week and everything's going to be amazing and I'm going to get all of these things done and that's my goal for this week. What if you don't get that done? That's not going to help your self-esteem and it's not going to help you feel very good about yourself. So if you start with a small goal, like today I'm going to brush my teeth. When you get that done, you can say, I accomplished something today. So helping the patient just to say like, let's start small. Don't overwhelm yourself with so many different things. That will help them build on it and start building hope and saying, okay, I can do things. I'm not completely useless. And then build hope for them. Say, you know, it does get better. We can help you get there. This is not the end. There is hope for you and we're going to support you. Use the placebo effect to your advantage. What does that mean? So we know that placebo in medicine means that sometimes we have an effect of benefit without the pill doing anything, right? That's how we do our clinical control trials. Is this placebo effect? Is this an actual effect of the medication more than placebo? It has been found in research that If a psychiatrist or a doctor prescribes the same antidepressant to the same person, what's going to make the big difference is what kind of relationship the person has with that doctor or that provider. So if I prescribed a medication to a patient with depression and I went on about building hope for them and making them feel good, and the pill is really going to help you, I'm going to support you. If it doesn't, let's try something else, versus somebody who says, here's your medication, and doesn't really like make them feel heard, I will have a better result with that patient than that other provider will have. That has been found in research. So things to know about antidepressants: they take about 4 to 8 weeks to start working. They should not be stopped immediately. So we need to continue to take them 8 to 12 months after feeling better. So if it takes 8 months to reach, if it takes 8 weeks to reach stability for that patient to say, I'm not depressed anymore, we want to continue that medication for about a year afterwards to help maintain that in the brain. When we think about antibiotics and having a 10-day course of antibiotics, so that way the infection and the bacteria is gone, similar, we want to continue taking this antidepressant for about 12 months. So that way our brain can make the structural changes to continue, so we don't need to be on this medication forever without feeling depressed. So some different options we have for antidepressants. There's different things, and I had a formulary to see what the most common medications are. Everything's different a little bit, you know, depending on where we are in the world. Citalopram is one option that's there for an SSRI. So that would be good for a patient who has depression, including difficulty sleeping and anxiety. So if you have a patient who's very nervous and having a difficult time going to sleep, they have lots of racing thoughts and they're nervous a lot, you can start citalopram for them. I would say to start at 10 milligrams. You could start at 20 if you need to, maybe for a larger person. And then you want to have them follow up in 4 weeks. So they're going to take 10 milligrams every day, follow up in 4 weeks. If the patient begins to have suicidal thoughts, or if the patient becomes what we call manic, has symptoms of mania, which we'll talk about, then they need to stop that medication immediately. That is your one exception to your patient stopping the medication immediately if it's making things worse. Sometimes if there's underlying bipolar disorder, it can cause suicidal thoughts for people if we give them antidepressants. We have to be very cautious about that. Once they come back in 4 weeks, as long as they're doing well, nothing really happened, a little bit better, we can increase by increments of 10 milligrams up to a maximum of 40 milligrams. Most common side effects found with citalopram would be tiredness. So I usually recommend patients take it in the evening, or GI upset. Most of the serotonin in our body is actually in our stomach. So when we take medications affecting serotonin for depression, like an SSRI, like citalopram, it actually causes GI upset as our stomach's kind of adjusting to that chemical change too. And then withdrawal symptoms. If we miss a dose of citalopram, even for a day, we might have these feelings of feeling disoriented, feeling like almost like life is choppy, is how people explain it. Like you feel like if you move your head, you get a little dizzy, a little vertigo. So that can happen if we miss a dose. It goes away as soon as you take the dose again. So if you just take it a couple hours late, you might notice you feel a little bit disoriented. And then there could also be sexual side effects. So that could be a loss of libido, and then men may experience a loss of ability to have an erection. So that is something you want to be very cautious about. It is something that people will often want to stop the medication for, and they might be too embarrassed to talk about why. We always want to pick one antidepressant to try for depression. Try it for, I would say, about 8 weeks. If it's not working, you can move to another one, but I would also just say don't mix antidepressants. You don't want to put citalopram in with another antidepressant. Try one. If it doesn't work, let's try something else. If you have a patient who's more lethargic and they feel more tired, fluoxetine could be a really good option. I would want to start fluoxetine or Prozac with 20 milligrams. So you want to start at 20 milligrams, have them come back in 4 weeks. How are you doing? You're doing well. Let's increase by another 20 milligrams if we need to, if you're not feeling 100% right now. But we do have to remember fluoxetine comes with a lot of medication interactions. One of those would be that it interacts heavily with HIV medications. So if you have antiviral medications for HIV, Prozac can affect that and cause toxicity sometimes. Citalopram would be a better option if somebody is on HIV medications. Amitriptyline and duloxetine are other options that should be available. Duloxetine is a really good antidepressant, but it does increase blood pressure pretty significantly. So if you have a patient who's hypertensive, this would not be a great option for them. If it is a good option and you have somebody with lower blood pressure, maybe the other antidepressants weren't really working for them, you could start at 30 milligrams and then increase by increments of 30 milligrams every 4 weeks until you reach a maximum of 90 to 120 milligrams. Preferably, I like to stay around 90, not 120, because 120 usually comes with more side effects than benefits. Amitriptyline is another option. Amitriptyline can be used for migraines. So if you have a patient with frequent migraines and also depression, this could be a good option. One of the problems with amitriptyline is it's completely lethal and it can cause dysrhythmias and death if overdosed on. So if you have a patient who's very suicidal, giving them a month's supply of amitriptyline could kill them if they decide to take all of those pills at once. It's not as forgiving as maybe fluoxetine or citalopram would be if you overdosed on those pills. So I would avoid this one in very suicidal patients. If you do want to use it and you have a patient who's fairly stable, just experiencing some depression, 10 or 25 milligrams, depending on the patient at bedtime, gradually increase up to 100 milligrams by increments of probably 25 every 4 weeks. Bipolar disorder. I made this graphic because I'm a very visual person. So when we look at this, I want us to start with, we'll start with major depression because we just talked about that. So depression. If we follow this red line here, this is a scale of 0, the lowest mood we've ever had, to a 10, the highest mood we've ever had. And then our horizontal is going to be over time. So let's just pretend this is weeks. I didn't put a time frame on it. But when we have depression, we might be at a normal mood for a long time and then dip. And we have an episode of 2 weeks or more right here where there's a low mood, maybe a 2 or a 3. Somebody's not feeling their best. And eventually that can kind of come out of that episode and we go back to feeling normal again, whether we have treatment or it resolves over a course of a few months by itself. Bipolar is different. Bipolar is a very severe depression, oftentimes significantly more severe than we would expect in a unipolar depression. So let's say our mood's at a 0 and we're at a 0 for a long time, and then mania happens, and then we go up to a 10, and we have a period of time where it's about maybe 5 to 14 days of feeling elevated at a level of a 10 on mood. And that's strange because we were just at a 0 for months. And now all of a sudden we're at a 10. And then it drops back down to a 0 very abruptly. And this is where suicide risk becomes very high for people with bipolar disorder. And you have these cycles of going up and down, which can be very dangerous. And then there's what's called bipolar 2 disorder, which is again, a very severe and long depression. And then we have a bump up. We're not quite at a 10 of like crazy high euphoric mood, but we're about an 8. We're feeling really good. We're feeling normal. But again, we have this very abrupt drop back into depression and our mood's at a 0 again, very abruptly. So these are things that could be very scary because we go to feeling amazing for a couple of weeks. And then all of a sudden we have this very abrupt drop and we think, what's wrong with me? Why does this keep happening? I was just feeling better. That can be very frustrating and dangerous for people with bipolar disorder. So what constitutes bipolar disorder? We have episodes of depression, like I said, with the mood of a 0, that switch into episodes of either hypomania, which is going up to about an 8, or mania, which is going up to about a 10 in mood. Switching occurs over days or weeks, not hours or minutes. So when we have bipolar disorder, sometimes people might think of, oh, that means you're moody or mood swing very often. It's very, they're like long-term mood swings. So it's not something that you would notice over the course of a couple hours, right? This is again, like you would be having an amazing mood for about a week and then drop into a very low mood, very consistent. So mania is very obvious. When you get to your mood of a 10, that can be very dangerous for you. That means you're doing very impulsive things. You're feeling amazing about yourself. But hypomania is a little bit less obvious. When your mood's about an 8, you're just feeling normal. You're feeling like you're functioning really well, right? So to make it more complicated, mixed states exist where you can have hypomania and depression at the same time, but we're not going to touch that. So signs and symptoms of mania or hypomania. So they're always going to be the same. It's just the severity that makes it either hypomanic or manic. So you're abnormally upbeat, your mood's very high. You might have increased energy and be running around. You have a hard time sitting still. Grandiosity, that means I feel better about myself than I've ever felt before. I am amazing. Wow, I'm beautiful and I should be rich. And I'm probably going to be the leader of the country tomorrow. I could run for president and I'm going to win. Whew. Euphoria, which is again, this very expansive, elevated mood. Decreased need for sleep. So not insomnia where it's like, I can't sleep, but I want to. This is people who just don't want to go to sleep. They can stay up for 42, 72, 100 hours and just not need to sleep. They like wake up and they keep going. They're cleaning all night and then they want to keep on going and doing more things. And eventually they'll crash. But that is probably the #1 indicator I can think of when I start assessing for mania or hypomania. Have you had periods of times where you have not needed sleep for days in a row? Maybe you're sleeping 2 hours and then you're just good. That's not something that we would normally expect, right? People who are very talkative and rapidly talking. So sometimes they're talking so fast, you have to really listen and say, like, what are you saying? And they might be jumping from topic to topic to topic and not making much sense. They might be distractible and have lots of ideas. I'm going to start a business. I'm going to do this. I'm going to do that. And it might seem a little bizarre for them. They will have impulse issues. That could be things like doing a lot of drugs, drinking a lot. That could be things like driving very fast, just doing things that are not in character for them. And then having racing thoughts, which you can tell by their speech. They're just really talking about a lot of different things at once. So mania, again, is very severe. It can get you in trouble. Hypomania, less severe. It's something that you're just functioning really well with, kind of like feeling great, right? But they will come into a depression, which is scary. And then we have psychosis and paranoia, which could also be symptoms of bipolar disorder. These are very common. These can also be common with schizophrenia or other kinds of things that can cause hallucinations or delusions. But oftentimes I do see this a lot with bipolar disorder, states of either depression or mania. It kind of mixes in there. So people with psychosis, so hallucinations, are more likely to be victims of violence than they are to be violent themselves. Very few people who are hallucinating are ever violent. So we have to remember that when we have somebody who's hallucinating. Sometimes there might be a stigma for us where we're like, oh, well, what if they do something to hurt somebody? We shouldn't be thinking that way. We should be thinking, what if someone hurts them? Because that's more likely statistically. It could be a symptom of a lot of different things. We treat them all very similarly. Typically, it can present as a feeling of someone's watching them, somebody's after me, somebody's going to come and kill me, somebody's poisoning me. They might be hearing voices, they might be hearing whispers that they can't really differentiate what it's saying. They might be hearing very loud voices telling them to do things. They might see things like bugs crawling, figures. I hear a lot about dark figures, other things that just aren't there. Or they might be feeling things moving and crawling on their skin. They might feel like they have superpowers, that they can read minds or predict the future. So those are all kinds of things to assess for too with bipolar disorder. Or if you hear them and a family member is saying like, hey, my daughter or my son just started exhibiting this, think about bipolar disorder. What do we do for bipolar depression? So we treat bipolar disorder in two different ways. We treat either mania or we treat depression. They're usually not treated the same way. So we have two different options for bipolar depression. We can either start with a monotherapy with an antipsychotic, something like risperidone, olanzapine, or haloperidol. Pick one. Don't use multiple at once. Don't use a little of one, a little of another. Pick one antipsychotic, try it out. Don't add multiple things. That can cause high side effect risk for patients. We don't need that. So that's one option that can really help with sleep, that can help with mood, that can help with psychosis. Or we can try something like lamotrigine. Lamotrigine is a mood stabilizer, which is also used for seizure disorders. We can use this and we can start at a very low dose and increase. And this is something that can help with what's called the kindling effect. The kindling effect means the more episodes of depression that we have that we're not treating, the more consistent and the more frequent and the more severe they're going to be. So our brain just gets kind of used to it and it's like, let's accelerate this a little bit. So we have to be cautious about that. Lamictal can stop that. So for Lamictal, we always start at 25 milligrams, wait about a week on 25, increase by increments of 25 milligrams weekly until reaching stability or 200 milligrams max. We're worried about Stevens-Johnson syndrome, specifically with Lamictal. So please have your patient know their skin, check their skin daily, and stop if a rash occurs. On lighter skin, it looks like a very flat, non-itchy, confluent rash. On darker skin, it can come off as more purple colored, but still very confluent, not raised. It is affected by estrogen, specifically birth control or pregnancy. So you might have to increase the dose of Lamictal if there is birth control in place or if there is a patient who becomes pregnant. For mania, we'd be looking at, again, using an antipsychotic, so something like risperidone or olanzapine, and we want to be a lot more aggressive with it. So we want to be maybe starting at like risperidone 1 milligram at nighttime, times about 2 days, and continue to increase by increments of a milligram every couple of days until that person starts sleeping, is more regular, is calm, is no longer manic. Olanzapine 10 milligrams for a couple of days, also an option, and then just continue to increase it up to 20 milligrams until you can get them sleeping back to feeling themselves again. Metabolic side effects are the biggest things we have to be concerned about for antipsychotics. So things like can increase the risk of diabetes, weight gain especially is an issue. And then gynecomastia is a side effect specifically to risperidone, which means that there can be breast tissue growth even in men in lactation development. So we want to monitor. I usually just have patients squeeze their nipple, or if they have breast tenderness or growth, I might have to stop that medication and try something else. Typically like olanzapine would be better. So again, just want to highlight, we don't want to ever treat bipolar disorder with antidepressants. That could cause suicidality, worsening of mood. They may come back initially. Say like you started a patient with bipolar on paroxetine or citalopram. They might come back that first month and say like, hey, I felt really good, but I'm starting to feel a little low again. Can we increase it? You'll increase it. And then they're going to come back a month later and say, I was feeling good for about a week and now I'm feeling worse. I'm feeling worse than I ever was. And then you might increase it again. And then we get into the cycle of just continuing to increase, but the patient is just having severe ups and downs. So when we go back to the mood spectrum, your patient goes from having one kind of up and down to lots of ups and downs. That's what antidepressants do. They cause us to more rapidly cycle through those ups and downs. So while we might think like, oh, they got better for a little bit, they had an up, that's not really what's happening when we look at like an overall pattern when we step back. So research tells us that we should not be using antidepressants for bipolar. Biggest things for bipolar, prioritize sleep. That's going to be the biggest thing. Exposure to bright light in the morning. If your patient is very manic to a dangerous level, please have them do bed rest. Have their family member keep them in a dark room about 6 p.m. to 6 a.m. Keep them there. That'll help their brain reset. Structure, exercise, reduce stress, reduce noise, reduce stimuli. Don't let them go out and like have all these family parties and adventures. This is not the time. Medication might be lifelong for bipolar, depending on its severity. I just want to touch briefly on perinatal and postpartum mood disorders too. So these kind of tie in with the depression and bipolar piece. Can we give pregnant women antidepressants or antipsychotics for different mood disorders and whatnot? Yes. And sometimes that's actually recommended. So if we look at the risks of untreated depression during pregnancy and postpartum, that can be horrible for both the mom and the baby. Not only do you have a mom who might want to kill herself and is no longer safe to be around herself or her baby, but we also have a higher risk of miscarriage. We have a higher risk of anxiety and depression later in life for that baby, cognitive issues for the baby, all sorts of issues from untreated depression. If we put in an antidepressant at the lowest effective dose, which might be the maximum dose, whatever dose makes her feel better and makes her stable, now we have a better outcome for mom to bond with baby, mom to be with baby, mom to feel better about herself, be able to care for her family, and we have less of a risk of miscarriage. Overall, we're looking at a lot better outcomes for both mom and baby with medication if depression is severe. So after mom has her baby, for the first 2 weeks, we have what's called the baby blues, which means moods are very up and down. We might feel very low. We might be crying very frequently. After those 2 weeks, if we're still having those symptoms of feeling tearful, not able to bond with baby, we need to consider postpartum depression. And that needs to consider treatment because that really affects mom's bond with baby. So we would want to avoid Paxil, paroxetine. That can cause birth defects. Citalopram can cause difficulty with getting pregnant, can also cause preterm labor, so we want to avoid that one. We can look at duloxetine, but we'd have to monitor the blood pressure. Fluoxetine, which is Prozac, that one can cause low birth weight or preterm labor, but overall it's fairly safe and there's a lot of research on it in pregnancy and postpartum for breastfeeding. Or amitriptyline, but we would just want to monitor the blood pressure. There's been no long-term intellectual or structural problems for any babies exposed to antidepressants, and they have followed babies born with exposure to antidepressants for decades after, and there's been no differences found in any of their function compared to unexposed babies. This is just a little graphic looking at symptoms of postpartum depression, which are essentially the same as normal depression, right? It just kind of happens with the hormone changes. Usually right after a baby is born, we have a 1000% drop in estrogen, which would make us feel a little bit erratic sometimes. So it's really important to be able to differentiate that and kind of help mom through those first couple of weeks. But when that continues to persist, that can be very devastating to a new mother. So we want to support her sleep, support nutrition, make sure she has a lot of community and people surrounding her. And then the alternative thing that could happen is what's called postpartum psychosis. So this is something that's associated with bipolar disorder. If you have a woman with bipolar disorder who gives birth, there's about a 20% chance that she might develop what's called postpartum psychosis. This happens to about 1% of all live births, to all live birth mothers. We need to be aware of it despite how rare it is. This is when moms start to have visual hallucinations, delusions of persecution, meaning that people are going to kill me, people are going to kill my baby, delusions around the infant, my baby is going to harm others, my baby's a witch, my baby has superpowers, my baby is a demon, something like that, that we're like, that seems a little odd, right? So what is the treatment for this? This is an emergency. If you have a psychiatric hospital that you can admit this patient to inpatient, that would be preferred. However, if you're in a rural area and you don't have that as an option, then gather family support and gather community support. If there are people who can help raise that baby while mom is recovering and getting sleep and prioritizing nutrition, all of those things, getting on medication, then that would be probably preferred, right? We want to make sure baby is safe, number one. Sometimes infanticide, right? People want to kill their babies after, and it's just postpartum psychosis that wasn't treated. So we want to really make sure baby is safe, but also that mom has support and that mom has people staying with her, watching her, supporting her, cooking for her, caring for her. We want to prioritize her sleep, safety plan, make sure that there's nothing she could harm herself with or harm baby with, and then medication. I would recommend olanzapine, 5 milligrams, increased by 5 milligrams until the patient is stable. You could do 5 milligrams in the morning, 10 milligrams at night, 10 in the morning, 10 at night, split it up how you need to, or risperidone, 1 milligram, and increase by increments of 1 milligram every couple of days until the patient is stable. This happens to about 50% of women. Well, about 50% of women this happens to, I should say, have had no psychiatric history ever. So they've all gone completely normal. All of a sudden they're 30 years old, they just had their first baby and they have this. So it's something we have to monitor for. Other considerations, suicide and homicide risk. So these are some sensitive questions that we do have to ask all of our patients who come in with depression or bipolar or postpartum, right? So we need to ask very directly, have you had thoughts of killing yourself? Do you have thoughts of killing or hurting anyone else? Do you have thoughts that you wish you were just dead? Do you have thoughts of killing yourself? If that patient says yes, they have what's called active suicidal ideation. That is a risk. Do you have thoughts that you wish you were just dead? That's passive suicidal ideation if they say yes. If a bus hit me tomorrow, that would be okay, but I have no plans or intent of doing that. Okay, they're not as high risk to me. I'm thinking that can be pretty normal for a lot of people who are just frustrated. We always want to ask if they say like, yes, I wish a bus would hit me. Well, do you have a plan? No. Or do you have plans of killing yourself? They might say, yeah, I'm going to hang myself. Do you have access to rope? Yes, I do have access to rope. Do you have intent to go do that? Yes, I have intent tomorrow at 4 o'clock. I'm going to go hang myself in our tree in our backyard. That would be pretty high risk if you ask me. That person has a plan. They have access to their plan and they have intent. Those are our 3 things we need to look for. The same thing for homicide, right? So do you have thoughts to kill someone else? Do you have a plan to kill them? Yes, I plan to shoot my neighbor. Do you have access to a gun? Yes, I have access to a gun and to my neighbor. Do you have intent to do that? Yes, I plan to do that tomorrow. Those are high risk people versus I have thoughts of killing someone, but I would never do that. Very different, very low risk, less likely to intervene. So you want to look at what's the risk and then what should I do, right? So how lethal is their method? Are they looking at like, oh, I'm going to hit my neighbor and I think he's going to die? A little bit less lethal than like, I'm going to shoot my neighbor, which would be a surefire death, right? Other little facts to think about, women are at higher risk of attempting suicide, but men are always going to be at a higher risk of succeeding for killing themselves. Men are more likely to use lethal methods than women. Teens and older people are at highest risk, especially like after some sort of a loss for older people. If they lose their partner, they lose their family members, they're alone, they don't have much support, they might be at higher risk of killing themselves. So just kind of looking at this, we're just looking at what's their risk level, how long have they been feeling this way. The highest risk is going to be if they have a danger on acting, they have a plan, they have access to their plan. So we really want a safety plan with these people to say like, what are our warning signs if we are feeling suicidal? Is there a crisis that's coming? And what kind of community support can I gather if I can't get this person to a hospital? And then really quick, signs of trauma. Sometimes these things will co-occur with bipolar or depression. If you have patients who've been through things like sexual assault, physical abuse, domestic violence, emotional abuse, any sort of thing, it could be loss. They might have symptoms that you're like, this isn't really adding up with the classic depression or bipolar, but there's something going on here. So hysteria, feeling very like all over the place, very labile, up and down, rapid mood swings over hours or minutes. Bipolar is weeks, remember, or days. Trauma is hours or minutes. You have somebody who's laughing one minute, upset the next, crying, yelling at somebody. That could be trauma. Children or adolescents will often run away from home. They'll act out. They may become aggressive. You might have 5-year-olds saying they want to kill themselves. They might be having regression and going backwards. They might be bedwetting. They might be withholding feces. They might have sexualized behaviors. These people may appear very jumpy, very easily startled. If there's a loud noise, they kind of jump and look around. They look nervous, on guard. They might be having panic attacks. They have frequent nightmares typically, or they relive their experience in some way. For kids, that might look like reliving it through play or through another, like aggression, yelling, different things like that. And then irritability, negativity, like thinking like something's always going to go wrong, nothing ever goes right, those types of things, feeling detached. I don't feel close to anyone. I don't want to feel close to anyone, and having poor focus. So trauma is something that's very prevalent through a lot of different communities, and a lot of people don't talk about it. So you could always ask somebody like, what's the worst thing that's ever happened to you? Has anything happened like that recently that's really affecting you? How is your sleep? How are you having nightmares? Is that affecting your ability to function? If you have somebody who's very anxious and who's very clearly got trauma and potentially disclosed it, a medication you can do, as long as there is no asthma, you can do propanolol. Propanolol, 10 to 20 milligrams a couple times a day to help bring the patient down and calm down, can be really helpful for them to get through while they're processing it. And then you could also consider an SSRI, something like citalopram, as long as there's no bipolar disorder. Assume that your trauma, psychological trauma, is universal in all your patients. Always treat your patients like they've gone through something bad, because honestly, they might have. Mental health education. So this is just looking at, we want to make sure that people are taking their medications daily if they're prescribed them. We don't want to stop them as soon as they feel better. Social support, spending time with families, exercise, helping them to find purpose, prioritizing sleep, and then help to empower your patients. I want to go through just a couple of these, and I want everyone to type in the chat whether they feel like it's bipolar, depression, postpartum, or postpartum psychosis. So 1 through 4. So patient is a 22-year-old female who presents with severe depression that has been going on for a year. She cannot get out of bed, cannot go to work, and often wants to die. She has difficulty eating and feels hopeless. Her mom tells you that a few weeks ago, she was completely healed. She was happy, she was not sleeping, running around, planning to go back to work, cleaning and cooking nonstop, and feeling great about herself. She does not know why she feels depressed again. If you guys could type in the chat and just participate a little bit for 1, 2, 3, or 4, 1 bipolar, 2 depression, 3 postpartum depression, or 4 postpartum psychosis, I would love just to see thoughts. So I'm seeing a lot of bipolar and a couple of depressions. So this is bipolar depression, actually. Yes. So, well, depression could be right. It's not a unipolar depression. This is actually a bipolar depression. The fact that we had a history recently, a couple of weeks ago, of the patient being healed and doing really well all of a sudden and feeling like they're back to normal. They're not sleeping, key, right? Running around, doing things, feeling great again. And then they sunk back into that depression. Think about that chart. They had their up and now they've taken that drastic down again, right? That indicates bipolar disorder, which would look at a treatment of something like an antipsychotic or lamotrigine for bipolar depression. Okay, patient is 6 weeks postpartum after her first delivery. She states she has been feeling very low, having a hard time bonding with her baby, and feels very angry with everyone around her. She's been having lots of hurting her baby, but then feels terrible and says she would never do that. She has not slept well and she feels like a terrible mom. She's crying as she tells you this. Is this 1, 2, 3, or 4? Bipolar, depression, postpartum depression, or postpartum psychosis? This one's tricky. Can I repeat the question? Patient is 6 weeks postpartum after her first delivery. She has been feeling very low, is having a hard time bonding with her baby, and feels very angry with everyone around her. She has been having thoughts of hurting her baby, but then feels terrible and says she would never do that. She has not slept well and she feels like a terrible mom. She's crying as she tells you this. Is this bipolar disorder, depression, postpartum depression, or postpartum psychosis? Excellent. Okay, I'm seeing a lot of postpartum depression, which is fantastic. So the fact that mom has thoughts of hurting her baby, but then feels really bad, that's okay. It's normal for new moms sometimes to want to throw their baby against the wall. Being a new mom myself, I'm like, oh, I've had those thoughts, but I never would do that. And I would feel really bad about having those thoughts, right? So the fact is she's in contact with reality enough to know that, yes, I'm having thoughts to hurt my baby, but no, I wouldn't do that. I'm just not feeling good right now. That's postpartum depression. Excellent. What about a patient who is 6 weeks postpartum after her first delivery? She has been feeling very low at times, has a hard time bonding with her baby. She feels very flat. She feels as her baby is a witch and she must get rid of it. She appears very calm as she discloses this. Is this bipolar, depression, postpartum depression, or postpartum psychosis? I'm seeing a lot of postpartum psychosis. So the key indicator here is, yes, we're having very bizarre thoughts, but the mom is very calm when she's talking about it. So there is a delusion in place, and the mom does have some delusions, yes, but she's also she's got a bizarre affect. She's very flat. She's not responding to emotion, and she's not in touch with reality to know that this is a really weird thought, right? So this would be postpartum psychosis. We'd be looking at using olanzapine or risperidone to help with this. And then finally, the patient is a 32-year-old male. He's never had issues, but in the last 2 months, he states he has a very low mood and has not enjoyed anything, even time with his family. He's not sleeping well and has lost a lot of weight. He feels very nervous all the time. He's not doing well at work because he cannot focus. He has thoughts of hanging himself, reasoning that his family would be better off without him. Is this bipolar disorder, depression, postpartum depression, or postpartum psychosis? Everyone's doing so good. I'm so happy. Perfect. So this is a unipolar depression. This is just regular old depression. We're not seeing any ups that are happening kind of intermittently. This is just like, we've been feeling really low for 2 months and we kind of want to die right now. So as far as the treatment, we'd be looking at something like a citalopram or a fluoxetine for this patient. Duloxetine or amitriptyline would also be options. Okay, and that is the end of my PowerPoint. I'm happy to take questions. Probably went a little bit over.
No, not a problem at all, Dr. Ngala. We have a lot of activity inside the Q&A section, and if you can see it, I'll go ahead and start reading the questions and you can answer them.
Okay.
The first question we have is it possible for a patient to fake depression?
Yes, absolutely. It would be possible for a patient to fake it, but the question would be like, what kind of gain or incentive would they be having, if any? And are we seeing that consistently? Is this something that, again, is affecting their function? But I would say that if we could do the PHQ-9, typically in my career, I've been doing this for several years, and I don't think I've ever seen anyone fake depression, unless there's some sort of an incentive, like they would get disability or maybe special treatment at home. But I would say it would be very unusual, but possible.
Wonderful. The next question we have is, does mania run in families, and what is its prognosis?
Yes, that is a fantastic question. Mania is extremely genetic. Bipolar disorder is extremely genetic. So if you ask somebody, has your mom or dad or grandpa or grandma, aunt or uncle ever experienced anything like you're experiencing right now, any mania, and they say yes, you can almost guarantee they're going to have bipolar disorder too, and I would treat them as such. Prognosis wise, bipolar is a chronic disease that we would probably need lifelong treatment for. If that patient has mania, it's a good chance they're going to have it again. So treating it would be the best option to prevent that from continuing to happen, but untreated mania has very poor prognosis to continue to happen. Fantastic.
Great. This is great. Next question. In postpartum depression, when do we stop the medication?
Also a fantastic question. So if I were to start the patient on, let's say, citalopram, and they got better within about 8 weeks completely, and they were completely stable on it, I would again wait about 8 months of being on that medication daily and then take them off of the medication, and they should be able to sustain that.
Great. Next question. Do children suffer from depression and how can we know?
Yeah, so I've definitely seen children as young as maybe 6 being treated for depression in my experience in pediatrics. Children having depression sometimes doesn't look as classic as adults having it that we had listed. Sometimes it comes off as more of defiance, irritability, lashing out at others, not paying attention in school, not doing as well in school, not caring about school, not wanting to go see their friends. So those would be the biggest indicators. So definitely ask children about suicide too, because children can also have suicidal thoughts.
It's a very important question. Thank you. The next one is, what are the indications for injectables in mental health?
Fantastic. Yeah. So if somebody is unable to take medication daily and have someone administer that for them daily, for instance, if they have a family member who could help give them their olanzapine or risperidone every day and help support them and watch them, and the community is able to support them, they might not need that injectable. But if they are constantly having episodes of psychosis and refusing medications and saying, no, you're poisoning me, I'm not going to take that, refusing, or they're forgetting and they don't have that kind of support, that would be an indication for an injectable. Injectables usually last about a month, and then they'd have to come back in for another one, but it would help keep them in enough right mind that they can't continue to refuse medication and continue to get worse.
That's fantastic. The next question is, there is a belief that hysteria/conversion syndrome can sometimes be due to high sexual desire. Is this true?
No, that's not true. Typically, if there was some sort of a hysteria or conversion disorder, I can almost guarantee you that that person has been sexually assaulted at some point, actually. So there's probably some sort of a trauma that's going on that may be causing those symptoms in the first place. But I can see where that would be confused. Typically, I would think it would be coming more from like a sexual assault or sexual violence that that person has incurred at some point in their life versus just high sexual desires.
That was a really important question. Thank you.
Yeah.
A female patient in her mid-20s, very active life, suffering from severe anxiety disorder. What is the best medication and what are the side effects that can come along?
For a patient with just organic, you're sure there's no bipolar disorder, I would say something like citalopram, 10 milligrams would be a really good starting dose for her. Have her come back in about a month, another 10 milligrams, get her up to like 20 or 30. And then side effects, it shouldn't slow her down. She might be tired for the first week. So usually the first week you'll be a little tired, and then it will kind of come out of it. Stomach upset. So as long as she takes it with food, she should be okay. But nausea is very common as far as at least the first couple of weeks. And then sometimes it can lessen libido. Those would be the biggest things, but she should be good if she already has an active lifestyle and she's in her 20s. She sounds pretty resilient already. So a little citalopram could probably help.
Great question. The next one, could you talk a little bit about attention deficit and hyperactivity disorder? Sorry.
Yeah, so that could be a whole webinar in itself, which would be really a fantastic topic too. So that's something that we're having a lot more awareness of these days, but this is something that begins in childhood. ADHD or attention deficit and hyperactivity disorder begins in childhood. And this is something that continues to stay with a person for their entire life. They have symptoms such as feeling like they're very talkative, they're interrupting, they're impulsive, they're unable to stay focused, they're unable to concentrate, they're losing things all the time, they're forgetful. There's a whole cluster of symptoms that can come with this. And when those have been present since childhood, that's when we consider ADHD. There are treatments available. I'm not sure what the most common treatments in East Africa would be for that. I know that there are different options here as far as like stimulant medications, non-stimulant medications, which can be beneficial to help with focus during those times, but it is a chronic lifelong disease. So a child who has this will continue to have these symptoms throughout their entire life. So adults often suffer through this as well.
That's great. The next question is, when do we decide to admit a patient?
So a couple of different things for admitting a patient. If they cannot, what's called contract for safety. So if you have a patient who says, I'm going to kill myself, I have a plan, that's enough for me to want a patient to go inpatient if they have a plan. If they have intent or access to that plan, that's an immediate admit. We definitely want that person to go inpatient. If they have thoughts to kill or hurt someone else and they are having delusions about it, really wanting to go at it, that would be enough to admit a person. Somebody with postpartum psychosis definitely could admit them. And I would say those are the biggest things. So are they a danger to themselves and we cannot keep them safe? They cannot keep themselves safe. Are they a danger to other people? Or are they hallucinating? Are they seeing things, hearing things, not able to care for themselves anymore? If they can't care for themselves and they don't have anyone to help care for them at home, please admit them.
It's a great question. The next question we have is pica a part of a mental disorder?
Yeah, so pica is something that people eat things that are not food. Pica can be a part of, well, pica technically is its own mental disorder as far as the DSM, the Diagnostic Statistical Manual goes, but sometimes it's also very related to things like autism spectrum disorder or different kinds of neurocognitive disorders. So if somebody has an intellectual delay, sometimes they will eat things that are not food. And then sometimes that can be related to neither, and that could be more along the lines of just anxiety or obsessive compulsive disorder.
It's fantastic. The next question we have is there a relationship between ADHD and the use of anticonvulsants in pediatrics?
That's a really great question. As of right now, there's no evidence or research that shows any sort of relationship between anticonvulsants and ADHD. However, if a patient is on anticonvulsants, perhaps for some sort of like a neurological disorder, seizures, epilepsy, that is related to ADHD. So patients who have epilepsy might be more likely to have ADHD-like symptoms.
That's great. And Dr. Ngala, for the next question, we'll take a live question from Danish.
Yes.
Danish, I'll go ahead and turn on your mic.
Yeah, as my question goes, when I was 16, we were attacked by thugs in our shop, and I watched my dad being killed. So from then, sometimes I have very severe mood swings. Yeah, and I was wondering, like, and sometimes I feel like maybe I disappointed him. I never acted. So could this be a sign of a mental instability or just a small feeling?
I'm so sorry that happened to you and that you went through that. I can't even imagine. I can tell you what you're experiencing, and we didn't go over this in depth, would be under the signs of trauma. You probably have what's called post-traumatic stress disorder. So post-traumatic stress disorder has those ups and downs, but what post-traumatic stress disorder is it means that when we're born, we're not expecting things that terrible to happen to us, right? Our brains are not made to process things that awful and inconceivable. So when those things happen, our brain says, I don't know what to do with this information, and it doesn't know how to file that memory away. It's not the same as like having, breakfast and you're like, oh, I ate breakfast today and I had, some eggs. It's not the same as eggs, right? Our brain's like, whoa, I don't know what to do with this. It's not like I ate eggs this morning. I saw something horrible. So it doesn't know how to put that memory away. So it just it floats around there, and it causes you to be irritable, and it causes you to have mood swings, and it causes you to have feelings of guilt. Like, what could I have done different? Did I not do enough? So that is all classic post-traumatic stress disorder. And I can't even imagine what you're going through. But I will say that's not mental instability at all. That's a very normal response that your brain has to something horrible that's happened.
Thank you.
Thank you, Danish, for sharing that with us. And again, I'm so sorry to hear that. The next question we have is, how common is misdiagnosis of mental health disease in practice?
Extremely common. Even for psychiatrists who have very thorough experience and training in this, it's still extremely common, because sometimes patients report things in a way that we might not expect. Sometimes we just don't have the knowledge to do that. I was reading some studies prior and looking at primary care doctors and primary care providers, and are they able to differentiate postpartum from depression, from bipolar disorder? And the answer is no. People have a really hard time with that. So they end up saying, this is nothing, or this is depression. And I'm going to call it depression, but it's actually bipolar disorder. On average in the United States, a person with bipolar disorder has a misdiagnosis for 10 years on average. So it could be much longer before they get the proper diagnosis of bipolar disorder. Extremely common.
Wow, and I think we may have time for one more question. How would you manage sociopaths or narcissists, traumatized empaths suffering from guilt, low self-esteem, and anxiety?
those are going to be more of like therapy type things that we can't manage in a primary care setting. Genuinely, we're going to be looking at a lot of like intensive therapy if available, or a lot of like just group work and having these people try to process things as best they can. But sometimes those things are very hard to work through. They're not easy fixes for sure. That's definite years sometimes that can go on for.
Wow, this has been absolutely fantastic. I think it's about time for us to wrap up. We're nearing our 1 hour mark, but we'd like to thank Dr. Ngala for taking the time out of her schedule to present on this extremely important topic. I think everyone can agree that we could have had this webinar last for a couple of hours and we still would run out of time, but we definitely thank you for taking the time, and I'll pass it on to you for closing remarks.
Awesome. Thank you so much for having me. And I hope this was helpful. And as far as like, there's so many more questions, I'm sure that we could kind of run through and go through as far as different topics. But I will say just be empathetic to patients that you encounter that are having any sort of mental health problems. And just remember that they may have gone through something really hard. So being kind to them is going to be the biggest way to help them heal, more so than medication could ever be.
Wow, powerful closing. Well, thank you so much to everyone for being here with the webinar. As a reminder, this will be posted on YouTube in 2 days, and we'll also share the slides, Eric, at the end of this webinar as well. But thank you to everyone for being here, and I hope everyone has a wonderful afternoon/evening. Bye, everyone.